Hello viewers, welcome to Medicine 24/7. The topic we will be discussing today is Disseminated Intravascular Coagulation. Please watch the video till the end and follow us on Instagram at Medicine 24/7 for more exciting medical contents.
Importance of disseminated intravascular coagulation in critical care wards is substantial, and it is a common occurrence as a secondary complication of various pathologic conditions. The contents we'll be focusing on today's discussion is the definition, etiology, pathogenesis, clinical features, diagnosis, and therapeutic measures of disseminated intravascular coagulation. So what is DIC? DIC is an acute, subacute, and chronic thrombohemorrhagic disorder. It is characterized by excessive activation of coagulation and formation of thrombi in microvasculature of the body. One thing we have to keep in mind that it is not a primary disease. It occurs in course of variety of clinical conditions. For example, in septicemia, widespread bacterial infection and the increased presence of bacteria and related toxins in blood is the primary disorder, and widespread activation of coagulation, or DIC, occurs as a secondary complication of that bacterial infection. Previous slide we mentioned that DIC is a thrombohemorrhagic disorder. So what is a thrombohemorrhagic disorder? In DIC, there is a thrombotic phase and a hemorrhagic phase. Well, it may sound contradicting, but there is certain underlying pathophysiology that we'll discuss later on. In acute onset of DIC with obstetric complications or major trauma is usually dominated by bleeding diathesis, or the hemorrhagic phase is more dominant in acute onset of DIC. Whereas in chronic onset of DIC, as occurs in cancer patients, tends to present with thrombotic complications. Let's have a look at the normal blood coagulation pathway. As we know, there are intrinsic pathway, which is a much slower pathway and triggered inside the blood vessels. The extrinsic pathway, which is a much faster pathway and it is triggered outside the blood vessels. And there is a common pathway where both intrinsic and extrinsic pathway merges with each other. The intrinsic pathway starts from factor 12 or Hagman's factor. The extrinsic pathway starts from factor 7, which binds with tissue factor or factor 3. This tissue factor has a substantial role in the pathogenesis of disseminated intravascular coagulation, as we'll see later on. The normal blood coagulation pathway can also be divided into three broad steps. The first is the formation of prothrombin activator. The prothrombin activator constitutes of activated factor 10, activated factor 5, tissue phospholipids, and calcium ions. The second step is the conversion of prothrombin to thrombin. And the last step is the conversion of fibrinogen to fibrin. Let's talk about the major causes leading to DIC. It can be caused by massive tissue injury, bacterial infections, widespread endothelial damage, and miscellaneous other causes. Massive tissue injury includes obstetrical complications like abruptio placenta, amniotic fluid embolism, and retained dead fetus. It can also be caused by massive trauma and metastatic malignancies. Infections include endotoxemia, gram-negative and meningococcal septicemia. Endotoxin is a product of gram-negative bacteria, which is lipopolysaccharide, and emia means presence in blood. So endotoxemia means presence of endotoxins or lipopolysaccharide in blood. Widespread endothelial damage can be caused by severe burns or aortic aneurysm. Miscellaneous other causes are snakebite, shock, and heat stroke. 50% of the affected individuals with DIC are obstetric patients with complications in their pregnancy. The 33% of the affected individuals are patients with carcinomatosis. The common cancers associated with DIC are acute promyelocytic leukemia and adenocarcinomas of lung, stomach, pancreas, and colon. Now let's talk about the pathophysiology of the disseminated intravascular coagulation. Disseminated intravascular coagulation has two primary triggers. The first is release of tissue factor or other procoagulants in the blood, and the second is widespread injury to the endothelial cells. There are many events which mediates the release of tissue factors. For example, sepsis, products of conception or presence of products of conception in blood, which are derived from obstetrical complications like amniotic fluid embolism. Also, it is released by massive tissue destruction, which is seen in burns or extensive surgical procedures. Increased presence of tissue factor in blood causes increased binding of tissue factor to factor 7, as we discussed in the normal blood coagulation pathway. So increased levels of tissue factor causes activation of the coagulation cascade via extrinsic pathway, and the activation of the extrinsic pathway leads to widespread macrovascular thrombosis. Widespread endothelial injury is primarily caused by deposition of antigen-antibody complexes. Deposition of antigen-antibody complexes can occur in several locations like SLE or systemic lupus erythematosus, which is an autoimmune disorder, burns, heat strokes, sepsis. In sepsis, bacterial antigens causes formation of antigen-antibody complexes, which further causes upregulation of the function of the cytokine Tnf. Many bacterial endotoxins, amniotic fluid, embolus, and other antigen-antibody complexes causes downregulation of thrombomodulin, which is present on the endothelial cells. It has a huge implication in the mechanism and pathogenesis of disseminated intravascular coagulation and widespread clot formation. Let's talk about the function of the cytokine TNF. TNF is a cytokine primarily released in response to inflammation or sepsis. Increased amount of TNF leads to increased expression of adhesion molecules, or specifically leukocyte adhesion molecules, on the endothelial cell surface. As a result, more and more leukocyte starts to adhere to the endothelial cellular surface, and the leukocytes starts to release reactive oxygen species and proteases. The release of ROS and proteases further accentuates the endothelial cellular injury. Now let's see how the endothelial injury causes activation of the coagulation. Whenever there is endothelial injury, there is exposed underlying collagen and VWF. VWF stands for von Willebrand factor, which binds to the GP1B or glycoprotein 1B receptors present on the platelets. As more and more platelets starts to adhere to the endothelial cellular surface due to exposed VWF, they leads to aggregate slowly, and this whole process is known as platelet adhesion and platelet aggregation. Whenever there is increased platelet aggregation, increased activation of the coagulation pathway, increased activation of tissue factor and extrinsic pathway causes widespread thrombosis. Bacterial endotoxins, or lipopolysaccharides, which stands for LPS, causes activation of factor 12 or Hagmann's factor. So we can see that the bacterial endotoxin initiates the intrinsic pathway. So disseminated intravascular coagulation is not only caused by extrinsic pathway activation, but in case of sepsis, intrinsic pathway also plays a role in the pathogenesis of DIC. Well, let's look at the consequences of the onset of DIC. We said before that it's a thrombohemorrhagic disorder. So as the name suggests, it has a thrombogenic consequences and it has some hemorrhagic consequences. Thrombogenic consequences include widespread fibrin deposition and MAHA, which stands for Microangiopathic Hemolytic Anemia. The hemorrhagic consequences include consumption coagulopathy and activation of the Plasmin system. The first thrombogenic consequence is hypoxic and Histamic injury. In DIC, whenever there is widespread intravascular activation of coagulation, it leads to widespread fibrin deposition and clot formation. Increased clot formation and presence of increased number of blood clots intravascularly causes occlusion of arteries and vascular beds. Occlusion of arteries leads to improper perfusion of tissue and risk of embolism. Improper perfusion of tissues leads to hypoxic and ischemic injury, as there is less amount of blood going into the tissues and the metabolic demands of the tissues increase. And if the hypoxic and ischemic injury is progressive, it leads to organ dysfunction and failure. The second consequence is MAHA, which stands for Microangiopathic Hemolytic Anemia. Whenever there is increased presence of clots in blood and arterial narrowing due to thrombosis, the blood flow becomes turbulent and there is increased shear stress on the blood cells, especially RBCs or erythrocytes. So there is consequent rupture of the erythrocytes or degenerated erythrocyte formation. It leads to development of a certain type of hemolytic anemia. Hemo means blood and lysis means destruction. So hemolysis means blood destruction, or in this case specifically erythrocyte destruction, which leads to anemia. The first hemorrhagic consequence we'll be looking at is consumption coagulopathy. Although disseminated intravascular coagulation causes increased activation of the coagulation pathways and increased clot formation in the blood, sometimes it leads to bleeding. It may seem contradicting. Well, let us look at the mechanism. Whenever there is increased formation of clot or increased activation of the coagulation pathways, there is increased consumption of clotting factors. Whenever there is too much consumption of clotting factors in the blood, the liver is unable to replenish the pool of clotting factors in blood, and the levels of clotting factors in blood become low, which leads to hemorrhage. This condition is known as consumption coagulopathy. The second hemorrhagic consequence is the activation of plasmin. Whenever there is widespread microvascular coagulation, it causes increased plasmin activity. Increased plasmin activity leads to increased fibrinolysis and proteolysis of the clotting factors. So remember, plasmin not only causes fibrinolysis of the clots, it also causes proteolysis of the clotting factors. So the depletion of clotting factors is expedited by the plasmin activation. It was already low due to consumption coagulopathy, but it is exaggerated by plasmin activation. Fibrinolysis and increased amount of fibrin split products in blood leads to inhibition of thrombin, platelet aggregation, and fibrin polymerization, which further leads to hemorrhage. The classic clinical manifestation of both acute and chronic DIC are dyspnea, cyanosis, respiratory failure, acute renal failure, convulsions and subsequent coma, cardiovascular failure, and shock. In meningococcemia and correlated intravascular coagulation, fibrin thrombi within the microcirculation of the adrenal cortex are the probable basis of the massive hemorrhages seen in Waterhouse-Friderichsen syndrome. Waterhouse-Friderichsen syndrome is a common complication of DIC caused by meningococcemia or sepsis caused by meningococcus. The diagnosis of DIC varies and depends upon the underlying disease. D-dimer study is one of the most useful tests to measure fibrinolysis. Often, the D-dimer study with increased levels of antithrombin complex is indicative of DIC. Other abnormal coagulation studies that help to confirm the diagnosis of DIC are increased bleeding time, increased PT-INR, which stands for Prothrombin time and international normalized ratio, increased partial thromboplastin time, increased fibrin split products levels in blood, and decreased fibrinogen levels and platelet count. The primary treatment of DIC is removal or correction of the underlying cause. So if the sepsis is causing DIC, we have to get rid of the sepsis first. If any obstetrical complication is leading to DIC, we have to get rid of the obstetrical complication. This is why in most of the cases, delivering the fetus often resolves the problem. Support of the major organ systems is also really important because in case of DIC, there is always increased chances of ischemic and hypoxic injury to the organs due to arterial occlusion. Replacement of the depleted clotting factors help to resolve the consumption coagulopathy and hemorrhagic disorders. Also, in case of any life-threatening hemorrhage, antifibrinolytics like aminocaproic acid can be used. Thank you for watching. If you have any doubts on the topic we discussed, feel free to DM us at Medikine247 on Instagram or comment down below. If you guys want the PPT of the topics we discuss on our channel or notes of the corresponding topics for free, you only need to subscribe to our YouTube channel and follow on Instagram at Medikine247 and DM us the topic. If you found our video informative and helpful, please like, share and subscribe to our channel for future medical video lectures. Don't forget to press that bell icon. See you on our next video on Medikine247. Stay healthy, stay safe.